Thank you for inviting me to talk about managing peritoneal dialysis catheter dysfunction as part of an ISPD lecture series. This lecture series is supported by an unrestricted educational grant from Baxter. In the following talk, I would like to cover these points. We want to talk about the relevance and impact of catheter dysfunction, the causes of peritoneal dialysis catheter dysfunction, the impact of catheter insertion techniques, how to diagnose catheter dysfunction, and its management. The spectrum of catheter dysfunction is dependent on the difference between the flow rate that's required and the flow rate that's delivered by the catheter. This point is important because if you think about CAPD versus APD, the flow rates required in CAPD are generally lower than those required in the automated peritoneal dialysis machine, and I've highlighted that here. Therefore, you're less likely to get catheter flow dysfunction in someone on CAPD than someone on APD. Clearly, the catheter has to work for both, but this may be an argument to start patients on CAPD first before then introducing APD once the catheter has settled down. Different services use different approaches to this problem. In this slide, I'm showing you a paper by Scanziani in NDT from 2003, an important paper because it explores the flow rates of the catheter. You can see initially you have an early flow rate as the fluid is draining out, for example. So you've got 2 litres in, draining out, and the flows go up to 350 or so mils per minute, but then they slow down at what's called the transition point. So when you've drained out to around about 85%, it's individual, of course. The flow rate often slows down at that point. This is known as the break point or transition point. And the value of knowing about that is that during APD, one can adjust the volume that's drained out using the tidal PD function to less than that break point if it's a particular problem for an individual patient. So, for example, one can limit flow problems and alarms by doing tidal APD in someone who's got a problem with very slow catheter flow after the break point. I've taken this slide from the UK Renal Registry report, and it's a table showing different types of access. On the left-hand side, arteriovenous fistulas for hemodialysis patients, tunneled lines, non-tunneled lines, and peritoneal dialysis access. And you can see the access in use at 3 months after placement. So for the fistulas, 85% were working at 3 months. But for the PD catheters, it was 84%. So despite the difficulties that we see with PD catheters, their functionality is very similar to that of a primary arteriovenous fistula. So this slide is taken from the Australian Renal Registry, looking at variations in technique failure according to the different contributory sites. And there's various adjustments in that slide, and you can see that the unadjusted data is in green with quite significant variation, and then adjusted for patient-level factors, a small reduction in the variation, but the bigger reduction in the variation occurs when center level factors are adjusted for also. And what that's telling us is that center factors, in other words, the way we practice PD at individual centers, is very important in terms of its impact on technique failure. And then we've listed the causes here of technique failure, and in particular, catheter dysfunction and mechanical problems are quite prominent, particularly in the early period. Therefore, we have the means to deliver a high-quality service with reduced access problems and reduced impact on technique failure. And that comes down to our individual centre practices. And I've taken this slide from a John Crabtree paper in PDI some time ago now, I think it's about 2010. He's looked at different insertion techniques and then looked at their complication rate. And you can see the different techniques listed on the left, from percutaneous to open surgical and laparoscopic. And on the right-hand side, in particular, you can see flow dysfunction. And it gives you a sense of the frequency of flow dysfunction that you might see in those different catheter types, ranging from very low, 2% in some studies, all the way up to 17.5% in others. Most prominent, actually, in the open surgical technique with this particular data set. And you can see that with 1 and 2 year catheter survival among these studies, there was a potential advantage for laparoscopic over open surgical. Systematic review and meta-analysis of the influence of PD catheter type on complication rate and survival. And what this systematic review is looking at is the type of catheter. And we've got coil tip. So those are the catheters with coiled tips at the intraperitoneal end versus straight tips, and looking at their impact, for example, on catheter survival. And you can see potential advantage for straight over coiled catheters, although not a strong enough advantage, I would argue, for people to change their individual practice. It just gives us an indication. laparoscopic insertion. Going back to laparoscopic insertion, here we have a meta-analysis from Badri Shrestha, also working in Sheffield, looking at cohort studies and looking at studies of the advanced technique. And you can see through that particular analysis that advanced laparoscopy, where there are a range of other techniques combined, such as amentorrhexy, adhesiolysis, or pre-peritoneal tunneling, other techniques that can be added using the laparoscope, that compared with open surgical, that there did appear to be an advantage in terms of catheter migration or in terms of catheter obstruction. In order to reduce the risk of tip migration, the self-locating catheter was developed. This is a catheter with a tungsten-weighted tip, and you can see it there on the plain film on the right. The gravity acts on the weight on the tip and keeps the tip in the pelvis, so that reduces the risk of migration. And there are several series of this catheter use. The downside is that the catheter tip can become fibrosed in the pelvis. 1 or 2 people have reported that. So clearly has a place, and it's an area of interest. So how does catheter dysfunction manifest? And most commonly this relates to outflow problems, although of course if the catheter really is not working at all, then you can have problems with inflow as well. Commonly it manifests as drain alarms on APD. It leads to large residual volumes and reduced ultrafiltration, and that can result in fluid overload and impaired clearance. And indeed large residual volumes can also increase intraperitoneal pressures and result in hernias and leaks. On the left-hand side I've showed you 2 panels from the Baxter Share Source remote patient monitoring of a patient on APD. In the top panel you can see some evidence of catheter dysfunction. When you get to the 3rd cycle, you can see the flow rate slowing down. Certainly on the 4th cycle that's evident. So with reduction in the duration of the dwell and a slow catheter drain, which impairs the catheter function and impairs the treatment. Having intervened and, for example, managed the person's bowels better so the catheter is working better, you can see on the lower panel much more prompt drainage and the treatment being delivered more effectively. So I certainly find being able to monitor catheter function remotely very helpful. A diabetic patient who recently started peritoneal dialysis became fluid overloaded. We did various things, including increasing furosemide, reducing fluid intake, increasing the volume of the icodextrin, but he remained with ultrafiltration difficulties and with low ultrafiltration of about 100 mils. You're also experiencing frequent alarms overnight. So what did we do? What would your protocol be? Early on in the protocol is a plain abdominal film, and in this plain abdominal film you can see the coiled catheter out of the pelvis and sitting over the right pelvic rim. So there we are. So on the right side of the pelvis, the coiled catheter out of the pelvis. So what kind of things can result in outflow failure? The most common one is constipation, of course, and that's very common in dialysis patients and affects catheter function in patients on PD, and a lot of attention is given to managing the bowel effectively. Catheter migration is common, and we've talked a bit about that. There may be a material that blocks the catheter, such as fibrin or proteinaceous material. There may be rapid absorption, for example, a high transporter absorbing the glucose quickly across the peritoneal membrane with low ultrafiltration. There might be mechanical causes of obstruction, such as omentum or oviductal fimbriae wrapping around the catheter, or adhesions, for example. On the right is a slide of someone using a fluoroscopic technique to reposition a catheter that's flipped out of the pelvis. A stepwise approach to managing catheter dysfunction. This, of course, depends on the underlying cause. It's important to check that all connections are open in the line and that there are no kinks, and it's important to examine the flow in and out and see how it works. That can often give good diagnostic information. Ensure that the bowels are working well. Undertake a plain abdominal film, because that will confirm the location of the catheter. Is it in the pelvis? And is the colon loaded? And then examine the effluent. For example, if it contains fibrin or proteinaceous material, that might be obstructing the catheter. And there might be value in using a thrombolytic agent such as urokinase into the catheter.